Hey, my name's Rick Mueller. I'm a professor in the economics department and a research affiliate here at the Prentice Institute. And I have a couple little housekeeping things here before I introduce our speaker today. Today's topic, sexual expression in residential care, supporting safe, healthy, and dignified expressions of sexuality in Alberta's continuing care facilities. And today's speaker is Julia Brassolotto, a Prentice Institute research affiliate and assistant professor of public health here in the Faculty of Health Sciences at the University of Lethbridge. She holds an Alberta Innovates-New Investigator Research Chair in Healthy Futures and Wellbeing in Rural Settings. That's quite the title. Yeah, how does that fit on the business card? Not too easy? No, too nice. Her research program looks at the care for older adults with a focus on continuing care contexts. Her background and training on health policy and equity. Broadly, her research interests include care work, rural health, long-term care, older adults, political economy, health sociology, health geography, social determinants of health, and healthcare ethics. These are some comments in that sentence. That's good. Originally from Ontario, she completed her undergraduate degree in philosophy at McMaster University, her master's in philosophy, bioethics, and PhD in health policy and equity were both earned from York University. During her PhD work, she spent time in Northern Alberta and BC. In Northern Alberta, she noticed the ways in which rurality, thank you. I don't use that word ever, obviously. Okay. Notice the ways in which rurality was a distinct determinant of health and had effects on other matters of health and healthcare. So I'll turn the next 50 minutes over to Julia, and I will be draconian with my time.
Great.
And there's a clock up there for your perusal too. So. Okay.
That's fine. Oh, thank you. Yeah, thank you all for coming today. So thank you for that introduction. That kind of introduces you to who I am and what my research is and what I'm interested in. Today we're going to be talking about sexual expression in residential care settings. And to give you a sense of what I'm going to cover, I'm going to introduce some of the key concepts that have to do with this topic around sexual expression and this particular context. So we're going to look at policy contexts as well as provincial contexts and issues specific to continuing care settings as well. And then I'm going to situate a research inquiry in those settings. So looking at what are we curious about that's happening in continuing care settings in the Alberta context. I'm then going to outline some of the challenges and tensions that we've identified in this research. So that includes in the literature, researching this, as well as in the interviews that we've been having to date and some of the data we've collected. So it's less a sharing of findings of the research that's underway and more an update about what some of the challenges are, what the problem is that needs to be investigated, and generating some conversation about this issue. Because what we found is that just getting the conversation started can be one of the huge barriers involved. So it gives you a snapshot of what lays ahead for our work. And when I say our work and I say we, I'm not just referring to my own work, I'm referring to the work of our team. So Dr. Lisa Howard is my co-principal investigator on this project. So you may also have some questions for her at the end as well. And we're also joined by Carly Ann Haney, who is a PhD student who I'm supervising, and she's also the study coordinator and the research associate for this project. And Al Manduka Barone is our research associate who works part-time. Carly Ann's background is in social work, and Al's is in bioethics, and he's done some policy advising for the College of Physicians and Surgeons of Ontario. So an interdisciplinary team with backgrounds in nursing and health policy, social work, bioethics. So we're bringing a bunch of different lenses to this issue. So I wanted to start out with a thought experiment, if you'll indulge me. So I'd like for each of you to imagine that you are the manager of a continuing care facility. And in this facility, you've just found out that there's a 78-year-old female resident who's been recently diagnosed with a sexually transmitted infection. She also has early-stage dementia. So nurses come to you and they let you know that she's been sexually involved with several different residents in the facility. And some of the housekeeping staff have complained because they've walked in on one of these encounters. So there are health issues, there are social dynamics at play here, and the nurses ask that you make a telephone call to the family of this resident. In this instance, let's say her son or daughter. And you need to call them and let them know the situation regarding their mother's health and her recent behavior. So think about that for a second. And on a scale of 1 to 5, 1 being not comfortable at all, 5 being incredibly comfortable and prepared. How comfortable do you think you would be making this telephone call? And you can shout out your answers.
1.
1.
3.
3. 1. Did I hear 3 as well? So, okay, there are many in the middle. Did anyone have anywhere between 4 and 5? No, okay. So why did you give it the rating that you did for your comfort level? I heard there was 1 3. And in that, and we'll get to that as well, but in that case, the designated guardian would be the person who actually makes decisions regarding the resident's finances, housing, and with whom she's allowed to socialize. So that's an important piece. But a lot of people, express to us that these aren't comfortable conversations to have. Right? And usually we see a variety of different levels of comfort, as we saw in this room. And you can imagine that if we had a different room, we might see a different range of levels of comfort as well. And so now I'd like you to entertain one other thought experiment. And now imagine that you are on the receiving end of this call, and this is a call about your mother. So I'm not going to ask you to use a Likert scale this time, but just to sort of think through, how would you feel receiving this call? And how would you begin to navigate supporting your mother through this kind of care planning? And how prepared do you feel to support, discuss, and have to weigh in on her sexual expression, her preferences, comfort level, consent to certain activities? So beginning to think through, and depending on people's mothers, it helps with the level of comfort as well, and openness about some of these things. But just starting to think through what it's like approaching this from different angles gives you a window into some of the challenges that Lisa and I are uncovering related to this topic, and it sort of sets the stage for some of the things that I'm going to tell you about today. So to make sure we're understanding the terms and language similarly, we'll talk about what is sexual expression. What are we referring to when we talk about this concept? First, I'll say there is no singular definition. It means many things to many people, and that changes over time, across cultures, across the lifespan. But we use the Hillman definition insofar as it captures the range related to sexual behavior, emotional intimacy, sensual activity, and sexual identity. So how we conceive of ourselves, maybe that's orientation or preferences, or just identifying ourselves as a sexual being or not. Right? So sexual expression also includes a freedom from having to participate in any of the things I've just listed. Right? And that's part of it too, and that needs to be included. So all of these types of sexual expression are influenced by a variety of factors. And Welch has highlighted that it includes biological factors, such as hormones, physical desires and abilities to participate in certain activities, psychosocial factors, such as feelings or attitudes, interactions and behaviors, and cultural factors related to media, education, religion, other institutional settings, and other cultural forces. So what sexual expression is always evolving, both on a societal level, but also on personal levels, and this changes over the course of our lives. And I don't mean that just insofar as what someone is interested in their 20s may be very different in their 70s, but I also mean it in the sense that it can change over the course of our lives because there are broad societal changes that happen as well, or different shifts in thinking and social norms. So several examples of sexual expression. What can this look like in practice? It can mean hand-holding, touching or grazing of hair, spooning, so two bodies lying together, pressed against one another, kissing or eye contact. It can also include some of the things we tend to more traditionally think of it associated with when we hear that language, things like masturbation or erotica, viewing of pornography, but also things like art, so painting or dance. And I often think about the pottery scene from Ghost, the movie Ghost, and how that's not explicitly a sex scene per se, but is sort of touted as one of the most romantic scenes in movie history. So kind of highlighting that sexual expression can really take different shapes and include different modes of expression. And that also includes self-presentation. So how we like to keep our hair, how we dress and our attire. And for some people that might have nothing to do with their sexual identity. For others it might be intimately tied to that. So thinking about sexual expression as being expressed in many, many different forms. And of course, it also includes sexual interactions with others, including intercourse. So when I talk about continuing care, I know that there are a few healthcare professionals in the room, but for those who aren't, it refers to the collection of services that are provided in the home. So we're not including home care in this because we're focused on residential care settings. So home care is part of the continuing care spectrum in Alberta, but it's not included in this study. So we're looking at supportive living and long-term care settings. So the difference between the two being the level of support that's needed. So in one, you have some assistance with nursing needs, with personal care, but there's also a little bit more autonomy and a little bit more flexibility. The second one, long-term care, is where there are more complex care needs and 24-hour nursing care. So both of those are included in what I'm talking about today. And sexual expression comes across very differently in this specific setting. For instance, there's a lack of privacy, and we refer to that both socially and spatially. So you can think about just the nature of a congregate living arrangement in general, like university dormitories. By nature, there is a lack of privacy because public spaces are used by everyone, and they can come and go at different times. Bedrooms are often shared. This is true of both universities and healthcare settings like this. And so within those spaces, we also see that they're heavily routinized. So especially in long-term care, there's a very strict routine that's adhered to in order to get everything done. So there's a wake-up time period, there are scheduled meals, scheduled activities, scheduled times for toileting and bathing and showering and all of these things. So it doesn't allow for a lot of spontaneity, doesn't allow for a lot of flexibility. And so it also means that a lot of these interactions are staff regulated. Staff have some say in who sits with who in the dining room, in where people are positioned during social activities to engage with each other. It may also mean that staff has some say, especially when capacity is diminished, of who socializes with one another. And so there's also staff in and out of rooms, which is different than, say, university dormitories, because there's housekeeping coming in and out, there's nursing staff and healthcare aides coming in and out, and there's also the fact that these rooms are usually not able to be locked from the inside. Right? So there's a level of privacy that's missing there as well because of that. And there's also a prevalence of dementia diagnoses in this context. So we see varying capacity to consent to certain activities. We also see certain disinhibition in sexual expression sometimes with dementia. So it changes the way that sexual expression manifests when you have a dementia diagnosis. And it also changes how we respond to it and support it or manage it. And also just acknowledging the fact that continuing care settings are clinical in nature. And that while there's a lot of people doing really great work to make sure that long-term care homes are homes and create a home-like environment, a lot of the time they still have an institutional feel. And the focus is on health outcomes and on things that can be measured according to biomedical measurements. So things like psychosocial needs tend to fall by the wayside when we prioritize things like measuring how much someone has eaten or whether they've had a bowel movement that day and what their levels are for various things we're monitoring. So again, just in that sense, some of these homes are also auxiliary hospitals. They're adjunct to an acute care setting, and sometimes that mentality can spill over. So it's not always a setting that feels like a home. And a couple other elements that Lisa and I have spoken about that are relevant to the continuing care setting is there can be a greater need for intimacy in continuing care because of cumulative losses that people have experienced up until that time. So there may be deaths in the family, there may be a loss of a partner, social roles, perhaps not giving care for children in the way that one did for a long time that was close to, that was part of one's identity. Social roles in the community, and activities and hobbies that people participate in that kind of enrich life, give meaning, a sense of purpose and connection and identity. So without those, that sense of intimacy with other people and that contact can become so much more important. And in terms of incoming cohorts, this is something we've heard about a lot from folks that we've spoken with. So, one participant said to us, my parents' generation thought doctors were gods, and if the healthcare professional told you that this is what had to happen, you didn't question it, and you accepted the service. She said, my generation and the baby boomers, when we're in there, we are going to be advocating for what we want, and we're going to be saying my social needs need to be met. And there are generalizations coming here that, of course, there are differences within cohorts. But there's also been a change in terms of social norms around sex and sexuality. So this incoming cohort now has lived through the sexual revolution of the 60s, has seen the free love movement with the hippies, has seen the women's movement and increased use of birth control and conversations about sex being something for pleasure and not just reproduction. There have been conversations, they've seen the legalization of same-sex marriage, and there's been a lot of changes now around public comfort with conversations around sex and sexuality. So even though there are still certain taboos and differences in personal comfort levels, on the whole, this cohort tends to be a little bit more vocal about these things. And so we're hearing from a lot of managers, this won't be kept silent for long. Mm-hmm. This is something we have to contend with and have to contend with yesterday. Also, this cohort may not have had sexual education for a very long time. May have received it in school years ago, and it might have looked quite different then, because there's new research, new social norms that have come into play, new resources available to support people. So updating that education as well is an important piece and relevant to this cohort. There's also a lot of people in continuing care who are under the age of 65. And so often people will speak about older adults in continuing care settings. They tend to group them all together at 65 plus, as though the needs, particularly in this context, of a 65-year-old and a 90-year-old would be exactly the same. But of course, it depends upon the person. And we see a huge variety and change people across decades there. So thinking about the fact that we're not just thinking about continuing care settings as places for the oldest old, but also as places that have to support people in their 30s with traumatic brain injuries and people in their 50s with multiple sclerosis. And their sexual expression can look quite different than someone in their 90s. So we have to think about this a little bit bigger than maybe traditionally we have. And so we've done a careful review of the literature and identified a number of different issues. One of the big ones right now is dementia and consent. I think in light of the Me Too movement and a lot of other public conversations around consent education, we're thinking about what does consent look like? Does it need to be affirmative and ongoing, and it requires certain components? But that gets complicated when dementia is in the picture as well. And so there's great conversations happening about, well, what does consent with dementia look like? And there's sometimes an all or none thinking around capacity to consent, thinking that if someone has a certain level of dementia, that then they are incapable of making certain choices, rather than assessing it case by case, moment by moment. And while someone might not be able to consent to a particular medical treatment because of the complexity of the treatment and not being able to fully appreciate all the potential consequences, they may still have the capacity to consent to hand-holding and immediate physical contact. So just starting to think through previous values and wishes that have been expressed related to sexual expression and how we could honor those right now, as well as reading responses in the moment and looking at what people are indicating they're comfortable with. This isn't that we're saying that it should be fully permissive and in every instance we should opt for supporting it. There are certainly cases where we want to prevent abuse, right? And so we're saying that it needs to be constantly assessed, case by case and moment by moment. There's also issues around personal attitudes and beliefs of staff. So we're within Alberta, there's a focus on client or person-centered care, and within that, you have to provide the care for this individual regardless of your own personal beliefs. But around sexual expression, that can cause challenges for people where the things that they're comfortable with might be different than the practices of the person for whom they're caring. There's also issues around the training and education of healthcare professionals. They get a little bit of this in one of the training modules that they go through, Supportive Pathways, which acknowledges that sexuality is a part of life and that it's healthy and normal. But it really doesn't give much in the way of tools for navigating the kinds of situations like we started with, our thought experiment. So a lot of staff feel that it's just they're troubleshooting on the fly for these things. That while they got a little bit of education that's meant to say this doesn't need to be uncomfortable and taboo, there are no resources to make it any less so. There's also the attitudes and beliefs of family members, which is one that we hear come up over and over again. That what is an issue for the family isn't always an issue for the residents or for the staff, and that often there's a disconnect between a present behavior and a family's idea of the person from before. And so sometimes it's that, so let's take an example where, say, mom and dad were married for many years, and dad is living in the community, and mom has dementia and is living in the care facility, and she doesn't always recognize dad. But now she's had this sexual awakening and has a romantic relationship with someone in the facility, right? So, while the staff might say, the husband's okay with it, he understands the situation, but the son is the designated agent who's making her decisions because she has dementia, and he doesn't feel comfortable with her having this relationship with this new person in the facility. He legally has the right to make the choice that she can't associate with him. So we see this disconnect here, and we're writing a paper about this challenge of agents and guardianship and trusteeship, and how that comes up specific to sexual expression, when there isn't an indication of harm, but there's an indication that there's discomfort at the family level. There's also shifting demographics, which I've spoken to as well, about new cohorts coming through who have different expectations, might use different languages, more familiarity with use of pornography or things like that. So if something's a practice in someone's life for many years before coming into continuing care, then to go cold turkey could be a bit of an adjustment. So how do we support that in a way that's safe and healthy and dignified for everyone involved? There's also health and social needs of LGBTQ+ residents. And so there's a lot of work being done within Alberta Health Services, looking at creating and maintaining safe and welcoming environments. But that work is still somewhat in the early stages. And so while there's things that you can put in policy about asking supportive questions and opening up conversations, well, how do you maintain that environment? And how do you navigate when issues do come up? And how do you make sure that you have the resources available to support people and not just say we support you, but to be able to live that out when things actually get a little more messy. And by messy, I just mean complex, right? There's also inappropriate or unhealthy expressions of sexuality, and those are hugely concerning because other residents and staff have every right to be free from the sexual expression of others. And so, sometimes this is framed then as problematic behaviors, and so geriatric mental health gets involved. In some cases, it can mean chemical restraints and hormones to kill desire and modify behaviors. And so there's looking at, well, how do we redirect certain energy? How do we respond to certain behaviors and say, well, if someone is behaving aggressively in this context, what are they seemingly asking for? Is there a recreation activity that will distract, and not in a sort of condescending way, just, well, we'll distract them with something else. But perhaps they're in need of human contact and there's an activity they can participate in that satisfies that and modifies the behavior. And not to say that some of the things being done already aren't helpful. There are some strategies that are quite effective and we're learning about those. But just highlighting the fact that we do see disinhibited behavior. And if we think about the Me Too movement and the fact that in all different industries, we're hearing about harassment that happens, continuing care is a bunch of people put together, and the kinds of things that happen in any other setting can happen here as well. So thinking about how people can be safe and respected. There's also a lot of assumptions that happen in continuing care settings. There's the assumption that it's only older adults, that I've addressed already. So thinking about everyone having needs in continuing care, and that being a space where lots of different people across age groups and cohorts might live together. So something like, is there birth control available on site, or contraception? contraception. So there might be something to prevent the spread of STIs, but if there's an assumption that no one there is of fertile age, then there may not be the kinds of resources necessary to support people. There's also assumptions about a limited interest or ability regarding sexual expression based on age or disability. So assumptions that older people aren't interested in sex or aren't capable of engaging in sex, or that people with disabilities aren't either. And both the evidence and every person we've talked to has indicated that this is not the case. Well, I'll get to why we initially designed this study, but we heard so many stories. As soon as we mentioned to someone that we were doing this study, they're like, I have a story for you. And almost without fail, every time. So, this just challenges that stereotype completely. There's also gendered tropes that play out around age and around ability, but things like the dirty old man trope. So if an older man who lives in this setting engages day to day with a select number of people, a new person comes in and he makes a flirtatious comment, there's sort of a labeling that can happen that has a certain assumption about this behavior and that it's either predatory or perverse or what have you, instead of maybe looking at it from multiple perspectives and considering, well, what's going on here and how can we support that expression in a way that doesn't make others uncomfortable. There's also the positively reinforced ladies' man, where there's sort of appraising or cute behavior around when this type of behavior is displayed, so that can encourage unhealthy expressions sometimes. There's tropes about the disinterested woman who has no interest, but I was thinking about during my postdoc, I was in a long-term care facility in Ontario, and we had a man on our research team who was about 25, conventionally attractive, and the women there were very vocal about how they felt about him, and regularly. And he even was invited back to someone's room after dinner, and when he politely declined, she said, "I'll pay you." So this idea that there isn't the desire there, or that older women, so there's ageist assumptions and gendered assumptions, what we're hearing and seeing challenges that as well. So one of our participants said to us, the thing about sexual expression in continuing care is that it's palatable when it's cute. But I know how Shannon feels about that word. But eroticism is then inappropriate. So if two older people are holding hands or dancing together after dinner, we say, isn't that cute? Isn't that so nice? They found each other, and it's this diminutive language. But then when it comes to something where they're expressing their erotic interests, or there's something more that we tend to think of as adult in their interaction, all of a sudden there's a level of discomfort or a sense of impropriety that comes with that. So saying, well, if we're telling them that that's healthy, that's intimacy, that that's all positive, well then we're sending a very different message if then shame and stigma come along at the next piece of that continuum. So how do these issues play out in Alberta? That's what Lisa and I were wondering, because we looked at the literature and we saw, okay, there are these issues surfacing around consent, around dementia, around all of these other pieces. But within Alberta, there are no formal policies or practice guidelines at the provincial level that focus on sexual expression. So what happens then is it's left to each facility to manage. Some facilities have their own guidelines that they've developed, most don't. The ones that have tend to not share them with others, nor do they often update and assess the effectiveness of their policies. So we also see no formal education for physicians, nurses, healthcare aides specific to sexual expression. So people are going in with very few resources available, but also little training in how to support that when these things arise. There are then, on top of that, limited opportunities for continuing ed about it. So we've asked, well, where did you hear about this before? And what kind of additional training opportunities are available for your staff when it comes to things like dementia and consent or LGBTQ plus care needs? And consistently, everyone has said there's nothing. There might be a workshop or something. I don't know if it's something we can attend. And so there's very little awareness of what's available and very little that's available. And in addition, there's varying degrees of public comfort with the issue, and there's diverse beliefs and attitudes about the place that sexual expression can have in continuing care settings. So our focus is on safe, healthy, and dignified expressions of sexuality for all parties involved. So it should be safe, healthy, and dignified for residents, should be safe, healthy, and dignified for families, and safe, healthy, and dignified for staff. And our research questions are, what are the current practices around sexual expression in Alberta's continuing care facilities? So in the absence of policy or guidelines, how are people navigating this? What resources are they turning to? What are they using to inform their decisions? What evidence base? And just basically, in light of the absence of all these other things, how do you fill that gap? We're also curious about the biggest challenges that facilities are facing and the promising practices that are happening there. And that's our language around the promising practices. With participants, we've talked more about successful strategies, or what's a time that you've seen this navigated really well, where you thought that was handled in a really safe, healthy, and dignified way. And so we're identifying some of these practices then as promising that we can share with others, because we've seen that there's this disconnect. And then we have a practical question as well, where we want to understand which types of resources or supports would be helpful for all the parties that I've mentioned. And so what drew us to this study was what I phrase as whispered conversations with friends and colleagues, because you'd hear these stories all the time, and I see a lot of the nurses nodding in here as well. And whenever, as I said before, whenever we'd broach it, people would say, well, I've got a story for you about that, or you know what, we need to be having this conversation and we just aren't. And this wasn't just from healthcare professionals. This was from colleagues here who've said, well, my mother-in-law is in long-term care right now, and here's this call that we got. And so starting to hear that now, there has to be an increase in comfort in the conversation because it's happening whether we're comfortable with it or not. So our shorthand that we use on our research team for the project is SHADES, and that's safe, healthy, and dignified expressions of sexuality. It also kind of connotes blinds, so privacy, and unfortunately also connotes 50 Shades of Grey, which is not our intention. Or my father's joke that we should call it 50 Shades of Grey hair. Not actually one that we would use. But again, this project is looking at these safe, healthy, and dignified expressions. So we've got 3 phases mapped out. The first one is underway, and it's almost complete. So I'm happy to report that. We're doing about 22 interviews with interviews, and we've done 2 focus groups with managers of continuing care facilities and with people who advise managers. So that could be zone directors, clinical ethicists, social workers, and other people who are consulted when an issue arises around sexual expression. And the reason that we focused on leadership roles rather than frontline care providers is because in the absence of policy, that's who's making all the decisions. That's who's setting the culture of the facility, and that's who's determining the facility level policies and practices. So we've had some great conversations so far. And for phase 2, we have our ethics underway. That's going to involve speaking with residents and family members. So we don't think we can only hear this from the staff perspective, because obviously there's a particular orientation, care provision, professional codes of ethics that inform that. But as you saw when we did our thought experiment, there's very different considerations when all of a sudden it's your family member. So asking family members, what would be useful to you? Because the things that might be useful to support staff may not be the same things, and likely aren't. Also speaking with residents themselves and saying, we're refining that guide, what our interview questions will include, but asking them about their lived experiences as the people on the front lines of this, with that experience. Phase 3 is in the early design stage, so we don't want to share too much about that just yet, but it is working towards our 3rd research question, where we're working with folks from AHS who are participants from phase 1 and phase 2, and the partners in phase 2 who aren't AHS employees, to develop some resources to support folks through navigating these issues. And again, that might be multiple outputs for different groups. But we're also interested not just in developing the supports, but also in then testing them. So developing the support, introducing it, and then seeing how effective it is and making modifications as needed. So in our conversations to date, we've identified some tensions and some challenges. Some of them will confirm some of the things from the literature that we've already talked about. Some extend or refine the themes from the literature. So we've seen a tension between individual rights and the collective agreement of congregate living. So when we agree to live with others, we have to give up certain amounts of privacy or control over decision making because it's collaborative and congregate. And so that plays out in interesting ways around the boundaries of sexual expression. So for instance, someone may have in their home, when they lived alone, walked around nude. Well, now all of a sudden, doing so in a congregate living setting has different implications. And I think there's reasonable expectations on boundaries there. There's also, as I've noted, the complexity around capacity to consent in light of dementia diagnoses and the roles that substitute decision makers have in these conversations. And really getting at, well, what's informing those decisions and how can we support people to make sure that that residents are allowed that quality of life where appropriate, where intimacy and human connection and contact can be expressed to its fullest, brightest extent possible. And we saw a disconnect between the wishes of families and residents. This is often flagged as a tension and a challenge. So finding a way to open up that conversation and developing some of the tools that we've talked about can give people not only some information, but some language to start that conversation with. Because you can tell when someone hasn't had the conversations before and just trying to reach for the right terms and not feeling comfortable and kind of squirming. So having even just say a booklet that explains dementia and sexuality that residents, families could be given, they may not read it. It may not change anything of their views or anything like that, but at least would then give them some language to have those conversations either with their relative or with the care staff. We've also seen a demand for normalization of sexuality and sexual expression, but we've also seen a hesitation to have the conversations. So people keep saying there shouldn't be a stigma, a taboo, it's totally normal. Everyone, is a sexual being one way or another on a different part of a spectrum of continuum of sexual expression. But then we say, well, then do you have this conversation with your clients? Well, they might think that that was improper and I wouldn't want to break the trusting relationship. Or I don't want to be sued because someone thinks that I'm broaching something inappropriately that isn't part of the care plan. So there's a lot of factors to consider there about why these conversations aren't happening beyond just comfort. There's also a tension between standards and standardization. So Lisa and I think, let me know if it's okay that I'm speaking for you here as well, and our participants to date have not felt that a blanket policy is the way to go here. We really think it's not about standardizing our approach to this, but really about having standards of care. So values-based approaches where you might have principles like safety, dignity, autonomy, and things like that. If you have a principled approach that guides care decisions, then you can honor those choices, but it can be flexible and adaptable to the person, to the situation, and can accommodate different views and values as well. So we think there should be certain standards of care around treating sexual expression and not just blanket uniform ways of doing this that are prescriptive and say, in X situation, do Y. If male resident is doing this, then this is the course of action. And a thing that we've heard multiple times too is that people just wing it. They've said, in the absence of these things, we just figure it out as we go, and it's very reactive. And it's drawing on what's already here and what we already know instead of reaching out beyond that to look for things that might allow us to do better. And the trouble with just winging it is that there's a lack of awareness of best practices. There's a lack of awareness of the evidence base to draw from or the resources and supports that people can consult to support these choices. There's inconsistency across sites. So even sites with the same management and ownership, we see a lot depends on the leadership of the facility and the family members. So sometimes, you may have a site that's very supportive, doing very safe, healthy, dignified things, and another site that's very restrictive, where residents aren't able to engage in meaningful connection with others. We also still see a lot of taboo, stigma, and shame, and those can be really powerful forces that really make people withdraw and feel badly about themselves, which is really challenging in an environment where social relationships and other identities and activities are more limited. And it also leads to unmet needs, where we manage people's behavior and expression through really biomedical clinical means, and don't then have the resources, time, or take the time to address some of those psychosocial needs. And also, just winging it can sometimes lead to distress or discomfort for family, for staff, and for other residents. So we see a problem then with just winging it. We think that we have to open up a conversation and acknowledge that remaining silent on this issue is just as radical a choice as being vocal about it. Right? That maintaining the status quo means maintaining the things that are harmful for people right now. And that's not to say that the status quo is all bad. There's also a lot of people doing really good supportive work. And sometimes that supportive work is on the preventative side. Sometimes it's on the supportive side or the responsive side. It can look very different. But we have to continue to open up these discussions and at least just acknowledge multiple viewpoints and address what we ought to do so that we honor a lot of people's values and priorities. So we said the conversations have to happen and change at multiple levels. It can't just be at the facility level. We need to engage at the provincial level as well, and at the level of just everyday conversations like this one with others, because we all have family members who may or who are or may end up there, and we all like to think that we won't. No one imagines themselves, or maybe some do. Most people we've spoken with don't tend to think of themselves as future residents. It's always about someone they know, but some of us may. And so thinking about, well, what would I want for myself or for people I care about or for members of my community? We also have to trouble assumptions about age, disability, and continuing care homes, and think about the complexities that we've highlighted in the literature and in the stories people have shared with us. And also we'd like to aim to ensure that sexuality in continuing care is safe, healthy, and dignified. So, as things unfold with our research, you can follow along our research updates on ResearchGate or on my Twitter account. And those are the references that I've mentioned today. So thank you for coming and for participating in the thought experiment at the beginning.
Thank you.